We're in the University of Bristol at the Bristol Brain Tumour Bank. Part of what we do is from patients who are having operations to remove tumours, we're asking if we can use part of their tissue we don't need for diagnosis for research. The overall outlook for brain tumour patients is very poor. So only about 14% of patients are alive after 5 years. So what normally happens to most brain tumour patients is the tumour is removed and they get chemotherapy and radiotherapy, and because the neurosurgeon is unable to remove all of the tumour because the tumour cells don't hold together, that the tumour comes back. This Brain Tumour Bank is a Southwest Brain Tumour Bank, so we take tumours from all over the Southwest. And the reason it's so important is because without the tissue, researchers can't understand what causes a brain tumour and what makes it progress, because these tumours come back and it's like evolution. So after it's treated for the first time, it changes and comes back differently. So only by looking at the tumour over time can we understand the differences in patients' tumour and try and eventually turn cancer into a chronic disease. We have three main projects at the moment. One is to help with early diagnosis of brain tumours. So can we develop a blood test for brain tumours? At the moment it's very difficult to diagnose them because the symptoms are so non-specific, so headache for example. So a blood test would really help. The other thing we're trying to do is trying to develop our understanding of brain cancers, because there are lots of drugs that we use on other cancers, but if we knew more about what causes a brain cancer in the first place, we could repurpose drugs used for other cancers for brain cancers. And the last thing that we're looking at is what are the risk factors for brain cancers, because after all, you're born with the cells in your brain, they're pretty protected from smoke and other environmental agents, so why do we get a cancer in the first place?
My project is looking at developing a blood test which could be used at a local GP centre. So on average, patients go to their GP over 5 times before they're referred. So if we can develop a technique which speeds this up and gets them for a referral quicker, it will also enable them to have their treatment course quicker. And also we can use this technique to monitor disease progression instead of having to keep going into the brain during an operation. So the technique I'm looking at is for circulating tumour cells. I'm looking at different technologies for this, and one of them isolates the tumour cells according to its size. So it's basically a filter which is big enough to let blood cells through, but small enough to block the tumour cells. These tumour cells can then be grown in cell media and characterised using single cell PCR or immunofluorescence. Another technique I'm looking at is for the specific markers on the tumour cell, and it uses beads which have antibodies specific for the markers on the tumour cells. And you mix the blood sample with the beads, and then you can filter these beads through and grow them in a similar manner to the other filter. So there's only a couple of cells probably in 6 mils of blood, and it's only recently discovered that in fact these tumour cells are floating around the blood, but previously they thought the blood-brain barrier prevented the tumour cells from entering into the blood. So these techniques have been developed for other cancers such as breast, but for brain tumour they didn't think it was possible. One of the markers I'm looking at is EGFR. Unfortunately, this method may not be as reliable as using a straight filter because the tumour cells evolve over time, so they may lose some of these markers, so you may not capture all the tumour cells, which is why I'm tending to go for more of a basic technique which just goes on the size of the tumour cell rather than specific markers. With the single cell PCR we could obviously look for specific genes which will enable us to determine whether specific treatments will work or not. Another area that I'm going to start looking into in the near future is for circulating DNA, and they've shown that circulating DNA levels are higher in CSF samples compared to bloods.
So there are main subtypes. The first is brain metastasis, and what I mean by that is that tumours have come from elsewhere in the body. So now as we're getting better at treating people's breast and lung tumours, we can have brain metastasis, and that's often what kills these patients. And we do have targeted treatments for those. So for example, if a breast cancer has estrogen receptors, we can give them tamoxifen as a type of drug, a targeted treatment for tumours that have that abnormality. In terms of the tumours that start within the brain, we're very limited in what we can offer patients. At the moment, we give them chemotherapy and radiotherapy, but one of our projects is to understand more about the different groups of tumours, because it's very clear to me, although I give 2 patients the same diagnosis, there are different abnormalities causing and driving their tumour, so that we need to know the specifics about what's wrong with your particular tumour so that we can give you targeted therapies. And the other thing to say is that a lot of these targeted therapies are already available, as I say, used for other conditions. So one of the problems is understanding what's wrong with the individual's tumour so that we can give them personalised targeted treatment. Initially, patients are consented for the operation to remove the tumour. So as part of the consent process, we ask the patient, can we use the tumour that's left over for research? So at the operation, the neurosurgeon takes out parts of the tumour and puts it straight into a vial, and we have a chute system. So in neurotheatres, they put the tumour into a vial which actually ends up in our lab, and it's snap frozen straight away with liquid nitrogen. So we make it very cold, and the reason we do that is because it's much easier to look at the DNA and the RNA and the protein within the sample if it's frozen very quickly.
It's very important to try and get our research out there and also increase awareness of the importance of consenting for the tumour bank or tumour bank and wherever else in the country. We just need to try and push research forward, and obviously it's not as easy to access this tissue as it is, for example, a breast operation. You don't want to go repeatedly into the head, so you need the tissue when it's taken in the first time.
We have interactions internationally and nationally also. So internationally, we've been working a lot with the University of Heidelberg, who are experts in next generation sequencing. So that's a genetic technique looking at the code of life within these tumours. So Hayley, one of my PhDs, has been over to Heidelberg and has been using their technology and have brought it back to Bristol. And the idea is if we can learn from them, that we will try and disseminate these techniques or provide a service for the whole of the UK. There is actually a network of 8 tumour banks that are trying to work together to make these resources more available to the community. These 8 brain tumour banks are going to work together. We're putting in a big grant this year to try and get a central coordinator, so that with every piece of tissue that's collected, we have all the clinical data on the patient and also the genetic data. So in terms of the abnormalities within the tumour, which have caused the abnormalities in each particular patient. And the idea behind that is that we could personalise treatments for patients. So rather than giving them blanket chemotherapy and radiotherapy that we do at the moment, we can use targeted treatments for their tumours. So people understand about organ donation. They understand about when someone is severely injured, about giving organs to help people live, but they don't realise that live patients, and in fact not only brain tumour patients but other patients having any operation, can give their tissue for research, and particularly in the case, because brain cancers are relatively rare, that every tumour is precious in terms of us understanding what's driving it, and if every patient could give us consent for research, we would be in a much better position. We know that actually all the patients that we survey would like to give their tumour for research that's not required for diagnosis. The problem is they don't know that they have to give us consent for research. And we did another survey and we found out that only about 1/3 of patients going through this journey are asked to use their tissue for research. And so they actually get quite upset when they realise that they've missed this opportunity to help other people. And actually giving consent for research is probably one of the most altruistic things that patients can do, because it's very unlikely to help that individual patient, but it will help future generations of brain tumour sufferers. So part of what we want to do is raise awareness to let patients know that they can help us fight this devastating disease by giving us consent to use the tissue that we don't need for diagnosis for research.